Hey everyone, we're going to get started. Next, I'd like to introduce Dr. Emma Evans, sorry about that, with Dogwood Emergency and Specialty Centers, Critical Care Team. And she will speak on respiratory care for the geriatric patient. Thank you.
All right, so can everybody hear me? Barely? That's probably good. Okay. So thanks for coming out. I know this is right before the raffle, so try to stay focused. But it's going to be hard. It's like Christmas. So I'm going to talk about respiratory distress in the geriatric patient. The goals of the presentation are to identify common causes of respiratory distress in the geriatric patient, to review physical exam findings that help us to localize respiratory disease, either to the upper respiratory tract, the lower respiratory tract, or pleural space, to focus on pleural effusions in the geriatric dog and cat, because I know that's my personal favorite emergency is the pleural effusion in the dog. That's sarcasm. It's the worst. And then to review principles of emergent stabilization and present clinical examples. If I ask you guys to participate, please participate, or else I'll just stare at you until you participate, which will be fine. Those are our goals. So the emergent approach to the patient in respiratory distress, I break it down into 3 steps. Step 1 is to provide oxygen. Flow by, ideally with a face mask to concentrate oxygen delivered. An oxygen cage is good. Nasal oxygen can work. And an e-collar oxygen tent. Do any of you guys use that? Have you tried that before? So that can work as well. Step 2, I like to provide anxiolysis, and so we know that anxiety and panting can worsen the cycle of respiratory distress, particularly in upper airway dogs, so laryngeal paralysis, brachycephalic airway dogs. We know that as they're panting, they're creating more inflammation in the upper airway, and they're also creating sort of negative pressure over the airway such that their airway collapses worse, and so I like to give them some anxiolytics. I like to use butorphanol plus minus a benzo. I one time went to a lecture where the speaker said that giving a benzo by itself is like giving 1 beer. It just sort of disinhibits them but doesn't necessarily achieve any sort of sedation or significant relaxation. And so I don't usually use a benzo by itself, but I really like butorphanol and benzos together. And you want to keep the patient breathing, and so you want to avoid drugs that cause both significant respiratory or cardiovascular depression. So drugs to avoid, can you guys think of some that you avoid? What's that? Okay. Yeah, people are I think ACE is sort of questionable because some people really like it because, it takes the edge off of the LARPAR dogs, but some people avoid ACE because it's not reversible. The ones I like to avoid are dexmedetomidine because that's sort of a stress test on the heart. So you're increasing afterload and also you're just kind of causing pretty significant cardiovascular changes. Ketamine can be nice because they will keep breathing if you give them ketamine, but at the same time, if you have a hypoxic sort of environment, the heart is very sensitive to hypoxia, and then you can potentiate arrhythmias with things like ketamine. And then Propofol is not a bad drug, but you have to be ready to take the airway, and so if you give them Propofol, they're likely to become apneic. And then step 3 is to localize the pathology. And so you're trying to localize respiratory distress to the upper, lower, pleural space, or none of the aforementioned. So there are respiratory lookalikes where I think we've probably all seen the DKA cat that comes in and you're going to be sure that there's a respiratory issue or respiratory component, but they're hyperventilating for metabolic reasons. So you're trying to localize where the disease is. The upper respiratory tract diseases would include brachycephalic airway syndrome, laryngeal paralysis, tracheal collapse, laryngeal obstructions, which can be masses or foreign bodies, and then tracheal obstructions. Lower respiratory tract are things like pneumonia, edema, which can be cardiogenic or non-cardiogenic, bronchitis or reactive airway disease, pulmonary hypertension, PTE, which I think we're starting to recognize more frequently, or at least suspecting more frequently, and on necropsy confirming it fairly frequently. Pulmonary contusions in cases of trauma, hemorrhage, an infiltrative neoplasia. Pleural space disease, so the pneumothorax or the pleural effusion cases in the pleural space, and then respiratory lookalikes, which can be pain, neurologic disease, metabolic or acid-based derangements. So how do you guys localize the respiratory pathology in your patients? Okay, so breathing patterns, looking at actual breathing patterns, and then probably through auscultation. So this is, let me see. Did I go one forward? Am I correct? No, that's good. So Dr. Hansen down at NC State made a presentation at ACVIM called How Sick Dogs Breathe, Characterizing Respiratory Pathology by Observation. And he breaks down sort of the things that you can look for in terms of breathing patterns that help you to localize sort of on triage what's going on. So he cites an audible long duration noise at the mouth, indicative of a large airway obstruction. Long inspiration and expiration is typically from a fixed upper airway or large airway obstruction, so brachycephalic disease, masses, abscesses, foreign bodies. Long inspiration with a normal exhalation can indicate a dynamic large airway obstruction, such as laryngeal paralysis. Long forceful exhalation with or without a cough can indicate intrathoracic collapse or obstruction. And then abdominal breathing indicates resistance to exhalation. And I think the most common, cases in which I see the abdominal breathing is in asthmatic cats. So it's almost like a COPD where they're trying to get air out, but they're trapping air in their lung. Vigorous excursions of the chest and abdomen are most indicative of pleural space disease, so pneumothorax, pleural effusion. And then fast, shallow breathing is usually characteristic of edema or inflammation, fibrosis, disseminated neoplasia. So that's pulmonary parenchymal diseases in the lower respiratory tract. So these are just a couple of articles that I found. How many of you guys are using ultrasound pretty frequently for respiratory disease? No? Well, that's kind of what these articles are talking about. They're asking whether or not it's time to replace physical, and these are human medicine articles, but is it time to replace physical exam and or auscultation with handheld ultrasound? And I think that that's probably not yet where we are, but it is worth considering. So this is an article, JAVMA 2011, Underlying Diseases in Dogs Referred to a Veterinary Teaching Hospital Because of Dyspnea, 229 cases. It's really nice because it breaks down the signalment of the dogs and then what they actually diagnosed as a cause of respiratory distress. The median age of all the dyspneic dogs was 6 years old. There were bulldogs, Jack Russells, English Springer Spaniels, Rotties that were significantly younger in this paper, and then mixed breed dogs were significantly older, as were Yorkies, German Shepherds, Dobermans, Greyhounds, Golden Retrievers, and Poodles. Dogs with upper airway and pleural space disease were significantly younger versus dogs with lower respiratory tract disease and cardiac disease. They were significantly older. Dogs with cardiac disease had significantly shorter duration of signs, which I think is interesting. So they usually had about a 3-day duration of clinical signs prior to presentation, whereas dogs with upper airway or obesity, stress-related dyspnea had a much longer duration of signs. This is a chart from that paper, which is a little bit blurry up there. But if you want to look up the paper, it just is nice because it does break it down by signalment and by frequency with which they saw these different disease processes as a cause of dyspnea. So we'll move on to pleural effusion in the geriatric dog, my personal favorite. And I'm going to give you guys a case. So this is Mitzi. Both of these cases that I use are made up. So this is Mitzi. She's a 14-year-old female spayed Maltipoo that presents to you at 5:30 on a Friday afternoon, so really good. She's here because she's just getting a routine exam prior to her dental. And when you go in to get a history, the owner says, well, she's got about a 48-hour history of lethargy, anorexia, and an increased respiratory rate and effort. So her vitals are temperature's 102.6. She's moderately tachycardic with a heart rate of about 148 and is mildly or moderately tachypnic with a respiratory rate of 50. And you note that she's got pretty decent respiratory effort. So the highlights from your physical exam, she's quiet but responsive. She's got a soft grade 2 out of 6 systolic murmur over her mitral valve. She's moderately tachycardic. Her femoral pulses feel synchronous to you. and strong. She's got quiet lung sounds with no obvious crackles or wheezes, and she's got moderate to marked respiratory effort with increased thoracic and abdominal excursions. So what do we do next? Do we obtain 3-view thoracic rads, provide oxygen and perform a brief thoracic ultrasound, provide oxygen and restrain for arterial sampling for a blood gas analysis, or do we go ahead and obtain that pre-anesthetic blood work for her planned dental? Yeah, so I mean, I think it depends on your resources and what you're comfortable with and what you would, what your preference is. I think getting some sort of imaging of her chest is a good idea. I think that ideally you would do something that requires minimal restraint because you don't want to stress them into a worsening crisis. So I would say either try to get a single radiograph just to kind of see what you can see, or provide oxygen and perform that brief thoracic ultrasound depending on what you're able to do. So we have ultrasound and we use it a lot. And so this is what you see when you ultrasound her. So you can see that her lung is kind of peeking out there, but pretty darn collapsed. She's got a large volume of pleural effusion, and that's her diaphragm kind of over to the left. If alternatively you get rads, you might see this, where that doesn't really give you much of an etiology, but you can see that she's just got a lot of soft tissue opacity, silhouetting with a cardiac silhouette, and so you suspect pleural effusion. So we know there's a bunch of different reasons to have pleural effusion. The 4 basic ones that we learned in vet school were from increased vascular permeability, and that can be from infection, it can be from cancer, it can be from other non-infectious causes of inflammation, so pancreatitis, something causing systemic inflammation can cause pleural effusion. You can have lymphatic obstruction, either from neoplasia that's kind of infiltrating and is a lymphatic neoplasia, or from an extra lymphatic neoplastic process that's causing obstruction to the lymphatics, as well as cardiac disease that can cause lymphatic obstruction. You can have decreased oncotic pressure, so leaking because you don't have enough protein in your vessels and enough oncotic pressure. That can be from things like protein-losing enteropathy, protein-losing nephropathy, liver failure, or other causes of low albumin. And you can also have decreased venous return or increased hydrostatic pressure, and that would be what we see with right-sided failure, pericardial effusion, or a venous thrombosis or obstruction. And then I put hemorrhage down there because obviously you can also have hemorrhage in your pleural space. So what do you do next? My recommendation is that if your patient comes in respiratory distress, you give them oxygen and then you address the cause of distress kind of prior to going down a rabbit hole of diagnostics, because you could do extensive diagnostics, but you need them to not die in order to get the rest of your diagnostics. And so if your patient is distressed due to significant volume pleural effusion, the best way to alleviate that is to tap the pleural effusion. So I would perform a thoracocentesis to alleviate emergent disease and distress. Again, I like to use something like butorphanol plus minus a benzo to take the edge off if you need to, and avoid those drugs that we already talked about. Save and submit the fluid for fluid analysis. Sometimes you might actually want to submit it for culture if you suspect that there's a bacterial infection or an infectious process. And if you're able to, you can obtain a total protein and a cytology in-house to kind of get a better idea of what the pleural effusion looks like. Additional diagnostics would include getting full blood, so a minimum database, and then repeating chest films post-tap to see if you can see anything structurally that's wrong after you do the tap. So you're not going to see a chest mass if it's surrounded by fluid. Once you do the tap, you may be able to see that. All right, so you remove about 300 mils of pleural effusion. She's now breathing much better. Her SpO2 is 97 to 98% on room air. Her heart rate is improved. Her murmur is still there. No surprise, you didn't fix that. And she's discharged for further recommendations to be made based on pending diagnostics. You run this blood work in-house. Her CBC is fine. Her chemistry is all within normal limits. Her PT, PTT are within normal limits. Urinalysis, fairly unremarkable. In-house fluid analysis shows a total protein of about 3.5. And you look at a cytology of the fluid and you see kind of a few inflammatory cells, segmented neutrophils, some small lymphocytes, and some macrophages. You repeat chest films and you don't see any significant findings. So no obvious masses and no obvious cardiomegaly. So you send out that fluid and you get back my least favorite thing to get back. And that is, it's a modified transudate. We don't see any obvious neoplastic cells. And so what are your differentials for that? Can you see the word differentials? Yep. Okay. I'm like at an odd angle here. So still almost anything. You haven't ruled out much of anything. Neoplasia, vasculitis, thrombosis, right-sided heart failure, still all on the list. Maybe you've ruled out hemorrhage, gross hemorrhage, chylothorax, pyothorax. Pyothorax is questionable because I would bet if you submit all of your modified transudates for culture, you may grow scant something on some of them, but that doesn't necessarily mean that's the etiology of the pleural effusion. So you get that fluid analysis back, and then fortuitously, Mitzi's owners have called. They say she's doing well at home, but she's starting to develop a mildly increased respiratory rate and respiratory effort again. So where do we go next? I think this is always the question that we all have. Do we go to an internist for advanced imaging and further workup of pleural effusion that's not cardiac, or do we go to the cardiologist for echo and further workup? So raise your hand if you would go to cardio. Okay, raise your hand if you go to the internist. No offense, Dr. Parker. Okay. All right. That's interesting. So I think either is a fair place to start. You can try to better discern the cause prior to referral using physical exam and medical history. So additional physical exam findings and diagnostic findings and history that would support right-sided heart failure, right? Because in dogs, pleural effusion is most commonly from right-sided, not left-sided disease, although there's anomalies, I'm sure. But things that would support that would be a murmur over the tricuspid valve. We didn't really hear that in Mitzi, but who can rule it out? An arrhythmia, so atrial fibrillation, ventricular tachycardia, other supraventricular tachycardias. Concurrent transudative abdominal effusion, so we know that the liver leaks sooner than the pleural vessels, and so when you're in right-sided failure, you should have abdominal effusion, at least a little bit, when you have pleural effusion from right-sided failure. Jugular venous distension or pulsation indicating increased pressures to the right heart, right-sided chamber enlargement on x-rays, hepatic venous distension on abdominal ultrasound, or a medical history that would raise the index of suspicion for pulmonary hypertension. So things including a chronic cough, a history of chronic bronchitis, progressive exercise intolerance, or increased respiratory rate and effort after you've corrected the pleural effusion, or an endocrinopathy that may predispose to thromboembolic disease. So we know things like Cushing's, hypothyroidism, those things increase our risk for thromboembolic disease. Do you guys know what this is? What's that? Yeah, so it's hepatic venous congestion or distension. Do you know what this is? Yeah, so it's the heart. And can you tell, do you know which chamber is which? Can you tell which is which on that view? Yeah, so it's hard because it's so distorted, but the bottom is so this bottom beating area is the left heart, and you're looking kind of down on that through the heart. The top is your right outflow tract, and it's way too big. So the right heart should be about a third the size of the left heart, and what's happening is the pressures are so high in the right heart that it's actually squishing the left heart and causing interventricular septal flattening, and so that's a dog with severe pulmonary hypertension, and that's courtesy of CVCA's echo that I borrowed. So without other evidence to support right-sided heart disease, I would probably lean towards an internist for this pleural effusion. I don't think it's wrong because an echo is easy enough to set up, and it may be cheaper than a whole workup for pleural effusion that's not cardiac, but I think either is fair. So without heart disease, what we go for would be an abdominal ultrasound to look for extrathoracic neoplasia or another source of vasculitis like a pancreatitis, and then potentially CT. So are you guys referring much for CTs? Do you refer much? Yeah. So CT has been proven to serve as a better evaluation of the mediastinal space. It can identify pleural thickening, which can actually suggest neoplasia versus just inflammation. And it's better able to identify venous thrombi. So we like CTs if they're available, but I realize it's an expensive test to get people to do. And then more expensive than that, potentially, would be pleural biopsies if you really just can't find anything structurally wrong. Pleural biopsies can get you a diagnosis of infiltrative disease, so mesothelioma, carcinoma, and other infiltrative neoplasia. So this is a veterinary radiology and ultrasound paper. Can malignant and inflammatory pleural effusions be distinguished using CT? What they found was that dogs with neoplastic pleural effusion were significantly older, and on CT more frequently had signs of pleural thickening. So it was sort of a helpful way to discern between a pleuritis and a neoplastic pleural effusion. Let's see. This paper, comparison of thoracic radiographs in single breath hold CT for detection of pulmonary nodules with metastatic neoplasia. I think the most important takeaway point from this paper is that CT is significantly more sensitive than thoracic radiographs for detecting nodules. So we detect them when they're smaller, we see them in more lung lobes, and we just know that it's overall a more sensitive test. And so it can pick up on things that we wouldn't see on chest rads. And then use of radiography in combination with CT for the assessment of non-cardiac thoracic disease in the dog and cat. Essentially, this was a paper from 2005. It also just says that you glean more information and sometimes new information on CT that you wouldn't have gotten from thoracic radiographs. So you may get more information on the location of the pathology, but also new information on the extent of pathology and regarding mediastinal structures. And actually, in these dogs and cats, they changed the diagnosis in 3 out of 5 cats and 13 of 28 dogs when they went on to do CT. And then this is use of thoracoscopy to determine the etiology of pleural effusion in dogs and cats. It was 18 cases. Essentially, it was just saying that when you can't find a diagnosis in any other way, getting a biopsy of the pleura can give you a diagnosis. They said it provides a less invasive alternative to thoracotomy, so you don't have to go for like a median sternotomy or a lateral thoracotomy, but it is effective in evaluating the etiology of pleural effusion. So what about Mitzi? So you referred her to an internist for further workup. Her abdominal ultrasound was normal. Pre-anesthetic echo showed mild mitral valve disease with a normal right heart. CT revealed pleural thickening, but no other structural abnormalities. Thoracoscopic biopsies were obtained and provided a diagnosis of mesothelioma. She was referred to an oncologist for further case management. So I think the take home there is that in dogs that come in with pleural space disease and that are distressed, tap it, try to alleviate the emergent distress. You can use things like butorphanol or a benzo as a safe sedation protocol. Always submit the effusion in the event that you get an answer. I think I've gotten an answer once on pleural effusion, but that doesn't mean don't do it. You should always do it. But then you should repeat films after you tap to make sure you're not missing a structural abnormality. And use your physical exam diagnostics and historical information to bifurcate whether you go cardiac or non-cardiac. And non-cardiac diseases can require an extensive additional workup and expensive.
What doses do you use?
I like to use 0.2 mg per kg as like a starting point. I think if they're nearly dead, 0.1 mg per kg or nothing may suffice. If it's like something that's lunging at you, then I usually do 0.4 mg per kg and 0.2 mg per kg of Valium as a combo. If it's lunging at you, I would not just do the Valium or the Midaz. So now we'll move on to pleural effusion in the geriatric cat. I want this bumper sticker. But that's because I'm a crazy cat person. This is kind of funny. I asked my friend to send me a picture of his cat looking like lethargic, reclusive, and distressed, and this is what I got. So it's about noon on Saturday morning when Mittens walks in. Mittens, well, he doesn't walk. He's carried in. Mittens is a 15-year-old male-neutered domestic short hair. He's here for an annual exam and vaccines. His owner does report a 3 to 4 day history of anorexia, reclusiveness, and a 12 to 24-hour history of increased respiratory rate and effort. You get vitals, which show a temperature of 99, a heart rate of 220, and a respiratory rate of about 70 with markedly increased effort. So subjectively, he's fractious and distressed, as most cats in respiratory distress tend to be. On auscultation, he has mildly muffled heart sounds. You can hear a gallop. His femoral pulses are present bilaterally. He has quiet lung sounds, and he's open mouth breathing with increased respiratory effort and increased thoracic and abdominal excursions. So next best step, this is another ask the audience. Do you administer oxygen and consider butorphanol IM for anxiolysis? Do you immediately obtain 3-view chest rads? Do you perform a brief thoracic ultrasound, or do you vaccinate him?
Nail trim and vaccinate.
Nail trim? That's a good one. Yeah, nail trim, do a fecal. Yeah. Yeah, right. So I think you guys get the gist, right? So the first thing we want to do is address any sort of significant distress with an anxiolytic if we can. Again, you can do butorphanol IM, you can do butorphanol and Valium IM or Midaz. And I think that's probably what I would do first. You should then immediately kind of try and sort out whether or not he needs to be tapped emergently. So you can get 3-view chest radiographs if you're able to give him some anti-anxiety meds and he calms down, but if he's still really worked up, I'd probably try to either tap him or use ultrasound to see what we're dealing with. So you do a brief thoracic ultrasound, which confirms large volume pleural effusion. Given his level of distress, you do tap him. You get about 200 mils of serosanguinous fluid. He's no longer open mouth breathing, and his effort is improved, but he remains tachypnic. So you put him back in oxygen, or you provide him with oxygen. You're going to submit that pleural effusion for fluid analysis, and then you're trying to determine, is this cardiac or not cardiac? So how many of you guys are using, it sounds like if you're not using ultrasound all that frequently, you're probably not doing brief echoes, but is anybody doing those? Sometimes? Okay. Brief echoes are kind of becoming like a new thing for ER doctors to try and get more proficient at, because they can give you some information quickly without the restraint of chest rads, and sometimes chest rads in cats can be difficult to interpret. You can also do brief lung ultrasound if you have lung ultrasound or ultrasound available. The SNAP Pro-BNP, is anybody using that? Yeah. And then repeat chest films after you tap to evaluate his cardiac silhouette and determine if additional pathology is present in the lungs, and then get your full baseline blood work, including CBC, chemistry, thyroid, all of those things. So I already asked you guys this, but it sounds like few of you are using ultrasound to help determine whether it's cardiac or non-cardiac. I'll still just show you some images so that if you guys get an ultrasound or you start to use it this way, you can have this as a reference. So the purpose of a brief emergency echo, I'll start with what it's not. It's not to replace a cardiology consult. So you're not trying to be a cardiologist, you're just trying to get a big picture idea of whether or not the left atrium is big. So the physics behind it is the left atrium, whether it's diameter or area, can be used as a surrogate measurement of left atrial pressure. Left atrial pressure approximates the pressure in the lungs, which is your pulmonary capillary wedge pressure, and an increase in pressure in the lungs predicts the risk for pulmonary edema. So putting it all together, if you have significant left atrial enlargement on brief echo, that's consistent with cardiogenic edema or pulmonary edema, pleural effusion. So here's a picture of a normal brief echo where you see the aorta is in the middle and then the left atrium is that like comma shape on the bottom. And so normally they should be about equal. So the left atrium should not be significantly bigger than the aorta. So your goal is to determine if the left atrium looks huge. The benefit is that it requires less restraint than 3-view thoracic radiographs in a dyspneic patient. The measurement is the cross-sectional diameter or area of the aorta versus the left atrium. In normal cats, the normal LA to AO is about less than 1.5 to 1. In most cats with congestive heart failure, their left atrium is significantly bigger than their aorta, so about 1.8 to 1 or larger. And again, the goal is not to be a cardiologist. Here's an example of a normal cat on the left and then an abnormal left atrium on the right. So can you guys see, obviously, there's the difference there. And that's something that if you're used to kind of like flashing the abdomen, looking for free fluid, looking for splenic masses, big picture, things like that, this is relatively easy to learn how to do. And what you're looking for is, you know, that left atrium just looks huge in comparison to the aorta. Regarding the Pro-BNP test, it does seem like it discerns between congestive heart failure and other causes of respiratory distress in cats. And so I think there's a cutoff value of about 265, at which it becomes sensitive and specific for congestive heart failure as a cause of respiratory distress in cats. And so I do think it's a nice test to have available just when you're trying to discern between the asthmatic cats and the heart failure cats. And how many of you guys said you have this available? Okay. This is what it looks like. It's just a colorimetric test, and so it'll go based on how dark the patient spot is, and so the patient spot can either be less dark than the control, the same color as the control, or darker than the control. And both the same color and darker than are an abnormal test. Lung ultrasound is getting really hot right now, so at least within ECC, but we're kind of all losers, so. Lung ultrasound, as it applies to the dyspneic geriatric patient, it can be used to evaluate dyspneic patients kind of on triage, so as soon as they come in. It was initially introduced in the context of trauma to evaluate for pleural space disease. So a hit by car, does it have a glide sign, which would indicate the absence of a pneumothorax? Does it not have a glide sign and it has a pneumothorax? But it's subsequently been evaluated as a diagnostic tool for edema in the lungs. And I'll show you what normal versus abnormal looks like here. It's a little bit hard to see, but your normal lung ultrasound should have this white line across the top that is then reflected just as an artifact. So that white line at the top is your pleural line, and then that can be reflected several times as you look through the lung field, but that would be normal. That's your A line. Your B lines, have you guys heard of lung comets or lung rockets on ultrasound? So that indicates fluid in the lungs or extravascular lung water. And so you're going to see these sort of hyperechoic vertical lines going down, and those are B lines, and that indicates edema in the lung. You can have infinity B lines, which actually looks like this last picture to the right, and that's just a lot of water in the lungs that's causing that. So this paper just looked at the frequency and number of B lines using this lung ultrasound in cats with radiographically normal lungs compared to those with left-sided heart failure, and found that normal cats that are not in heart failure had very few B lines, whereas cats that were in heart failure had a lot of B lines at every site that they looked at on lung ultrasound. But there are limitations to lung ultrasound, and that is that it doesn't discern between cardiogenic pulmonary edema and other causes of diffuse edema in the lungs. So things like a non-cardiogenic edema where the patient has choked or they've been electrocuted, or cases where you have something like ARDS from another systemic illness that's caused injury to the lung. So here's your update on Mittens. Has an abnormal SNAP pro-BNP, has an enlarged left atrium on brief echo, has cardiomegaly, moderate pulmonary edema, and scant pleural effusion on post-tap recheck chest rads. Blood work is all relatively normal. What's the next best step for Mittens? CBCA. Yeah. Yeah, what they love the most is when you just punt them directly there without doing anything else. That's what I found goes really well, even when I try to do it. So what I would say is yes, I think ultimately a cardio consult is going to be a good next move. I think giving Mittens some Lasix kind of empirically, because we can see the pulmonary edema, we've tapped the pleural effusion, and we have all of these indications that that he's got heart disease. I think that would also be helpful in making them more receptive to your appointment. So take-home points regarding pleural effusion in cats are that you should perform thoracocentesis emergently if needed, provide oxygen and anxiolytic medications prior to additional diagnostics that may cause stress. Cats, have any of you experienced having a cat die trying to get chest rads? Like a respiratory distress. So they're just really weird because they seem like they're going to be okay, they're fighting you, and then they die. And then you feel badly that happened. So I would say try to provide them with what they need and sort it a little more before you stress them out with diagnostics. And ultrasound can be used as an alternative to chest rads to ascertain information about pleural space, pulmonary parenchymal, and heart size, pulmonary parenchymal disease and heart size. And pro-BNP can help to discern cardiac from non-cardiac causes of dyspnea. So the conclusions are just that use your physical exam and observation of breathing pattern to localize respiratory pathology, break the cycle of dyspnea with oxygen and anxiolysis, prioritize stabilization over diagnostics, and depending on the etiology, referral for further diagnostics, including advanced imaging and biopsies, may be indicated. Questions? references. All right, thanks. Thank you.